Okay, I'm ready. Are you ready? I've got my zombie stick. I've got my notes. Anyways, going to be talking about some general health concerns and screenings that you need to know about today. First off, I'm going to throw out a shameless plug to my Patreon page, patreon.com/otherclinic. All donations that patrons make through there is going to go towards people that are struggling here with our clinic to afford their hormone costs and whatnot. Check it out. You get early access to the YouTube videos, easier access to me. You ask questions, make requests for the videos, and even have your own case reviewed. Anyways, check it out. It's interesting. Anyways, so moving right along. When you go on hormone therapy, there are some things that, of course, change about your body, which can change the course of your future. Your health future is really what I'm talking about, because, whenever you get towards, your 40s and 50s and everything, there are certain screenings that we all hear about whenever we're younger, and, that I'm experiencing now because I'm 41. But anyway, that we need to know about. Do we still need to go to those? Do we go more frequently, less frequently? What's going on? So I'm going to try and cover those, and I made a lot of notes because, literally, this is covered in a lot of continuing education when it comes to trans medicine stuff, but it's usually on very, very long and boring lectures that they're awful to sit through. They're just awful. So I sat through one that was 3 hours and another one that was about 2.5 hours, and then spent some time researching and looking up to clarify some of what they said, to compile my own little notes here. These are going to be the general recommendations because, of course, with trans medicine, there is a lot of research out there for some things, but then other things are just woefully left in the dark, such as what to do, for example, with someone who is now developing breast tissue on estrogen therapy. When do you start breast cancer screenings and such? And so they're not as clear cut as we would like, but there are some general recommendations from the major organizations that make these rules for cisgender people that now have their kind of loose recommendations for transgender people as well. So this is what we have at this point in time, and so that is what we're going to talk about. A brief disclaimer, I will be using anatomically correct terms, so if you don't like hearing those, I apologize, but there can be no ambiguity here, no misunderstandings about which parts I'm talking about. We can't just have me saying bottom area and I'm expecting you to know that I'm talking about a particular part of that bottom area. So I will be using anatomically correct terms. Apologies in advance. I'll try to minimize the use, but I do need to be very clear about some of this stuff. So without further ado, the first thing we're going to talk about is the chest. So whether you are trans femme, trans masc, non-binary, whatever, you're on hormone therapy, you're probably either going to be growing some breast tissue or maybe kind of hoping that some wasn't there. But what do you do with it when you have it? Let's talk first about trans femme individuals who are going to be developing breast tissue. So you go on estrogen therapy, you start developing breast tissue, woo, everybody's excited, right? All right, but when do you have to start doing self-breast exams? When do you have to get mammograms? So when you first start developing breast tissue, whenever it's just noticeable that something is happening on the chest, from that point in time, you should be doing some form of self-breast exams. I have a video linked somewhere in my site, and I'll probably put a link below as well, to a very good animated video that shows how to go about doing a self-breast exam. It's really cool. It kind of shows the inside of the body whenever you're pressing down from the outside, like what you're actually feeling for. So I'll put that link down below in the video description. But anyway, so from the moment that you actually have any discernible breast tissue arising from the chest wall, you should be doing some type of self-breast exam every month, same time of month, every single time. Be consistent with it. Best place to do it is in the shower because it's easy to slide around on there. But it is important also to maybe lie down here and there and feel whenever you're laying down, because the tissue can shift and you can feel different areas whenever you're lying down as opposed to whenever you're standing up. So check out that video and start doing yourself breast exams every month. Haha. Now then, at what point would you say that you need to start getting mammograms? So this has been debated a lot in the organizations that are out there, and what they've essentially come up with is following your local organization guidelines, which are usually going to look somewhat like this. If you have a high risk of breast cancer, such as first degree female relatives in your family, such as your mother and your aunts, or sisters or something like that, someone very close in your family tree that has had breast cancer, and then you are at a higher risk for it. If you have a couple of people in your family tree like that have had it, you're higher risk. So the higher your risk, the sooner you should start getting mammograms and professional screenings. So what this means, or how it has translated for these organizations' recommendations, is that you should, once you're on hormone therapy and you have been on estrogen therapy for a minimum of 5 years, and you are above the current age of which, if you were a cis woman, that you would then begin getting a mammogram, which, say for myself, I have a couple of relatives that are close who have had breast cancer. So at age 40, and now I'm 41, I start getting mammograms. Same would be for you. If you started hormone therapy when you're 35, say, and 5 years later you're 40 and you have a couple of female relatives who have had breast cancer, you should start getting your mammograms once every year or other year. It depends on the provider you have and which guidelines they're following. You should discuss that with your provider and see which you're comfortable with. But 5 years of hormone therapy or more, and age of either 40 or 45 or 50, depending on your individual risk factors and which set of guidelines that you and your provider decide are appropriate for you, you should start mammograms. Whether you need a healthcare provider to do a yearly breast exam on you or not, I haven't really seen them address that. If you're doing your monthly screenings, I can guarantee you, as a healthcare provider myself, you will find that lump or difference in your chest way before we ever will. I think the saying or the finding was that patients are finding lumps whenever they are the size of a dime, and healthcare providers are finding them when they're the size of a quarter. So if you're doing your breast exams yourself, you're probably going to be better off than just relying on a once yearly breast exam done by a healthcare provider. There's no current recommendation that I've seen for, do you need to at a certain point have a healthcare provider do that? So I would advise, I guess, just going with, the once yearly thing like they have cis women do. It won't hurt anything, certainly, but just remember to do your own breast exam, because that is what is most important. Anyway, so moving on just a little bit to the topic of cancer risk, because everybody wonders about what exactly is the risk of cancer, then breast cancer that is, whenever you're trans feminine, or trans masculine for that matter, but trans feminine right now, what we're talking about. So what they have discovered with the limited studies we have, of course, is that it appears that trans women are at an increased risk for breast cancer than they would have been at baseline once they go on estrogen therapy. So compared to cisgender men, trans women are at an increased risk for breast cancer being on estrogen therapy, which just kind of makes sense. But compared to cisgender women, trans women seem to be at a lower risk for breast cancer. Now, this is due to many different factors, because we have discerned that breast cancer risk seems dependent on estrogen exposure over time. Now, the vast majority of trans feminine people haven't been exposed to estrogen at the same height anyway that cisgender women have for the exact same length of time. Because you think of it, if a cisgender woman goes through puberty and starts having higher levels of estrogen around age 11, 12, even earlier in some cases, then, you know, trans feminine person, like a lot of my patients start in their 20s or 30s. And, you know, so they have a decade or 2 decades behind in exposure time to estrogen that a cisgender woman does. So it's, you know, I mean, there's a silver lining for everything. While it sucks that you had to wait, I guess, you know, it decreased your risk for breast cancer. Trying to look for the positive. But anyway, so just something to be aware of, that you are at a higher risk for breast cancer once you start estrogen therapy, but not quite as high as your same-aged cisgender women peers. Anyways, so then, moving right along to transgender masculine people who are on testosterone therapy. So what about your chest? What about your breast tissue? What should you be doing with it? You should still be doing self-breast exams every month. Sorry, it sucks, I know, but if you have the parts, you need to check them out, because you don't want to be that guy who ends up with breast cancer. That just sucks. Cis men can get breast cancer. It's very, very uncommon, but they can, and so can you, because you had more exposure to estrogen than the cisgender men did. So keep an eye on that stuff. Do your monthly breast exams. Do them appropriately. Check out the link to the video if you don't know how to do them. And then your screenings and mammograms should be along the same timelines that I mentioned for the transgender feminine people and cis women as well. You know, if you're at high risk, start it at 40. If you are at moderate risk, maybe around 45. And if you're at, you know, just no real risk at all, no family members ever have had breast cancer, and, you know, you haven't ever been on any kind of estrogen therapy or anything of any significance, you know, you could potentially then wait till 50, depending on the guidelines you're following. It depends. You really need to talk this over with your healthcare provider, though, so that y'all are on the same page of what you're okay with and what you're not okay with. So every month, exams, and then 40, 45, or 50, talk with your healthcare provider about when you then need to start mammograms, but most definitely start thinking about it at least around 40. Now, studies have shown it does look like transmasculine people on testosterone have potentially a lower breast cancer risk than their cisgender female peers do, which makes sense because, you know, even though testosterone in and of itself doesn't like block the effects of estrogen exactly, and it doesn't like decrease the production of estrogen as significantly as in trans feminine people. When trans feminine people take estrogen, it blocks testosterone down to the ground, but whenever trans masculine people take testosterone, it does not do the same thing to estrogen. But it does, to a point, decrease it somewhat. Some studies say it may be 20 to 30% reduction in overall estrogen production. But that does seem to decrease your amount of estrogen exposure over time. And then especially if testosterone stops your menstrual cycle, then you will have just kind of a steady estradiol level most of the time. Which means no high spikes and things like that, which again decreases your exposure to estrogen over time and can decrease your breast cancer risk. So that explains, you know, why transmasculine people on testosterone do seem to have a lower risk overall for breast cancer, but that's no excuse to not be doing your screenings and taking care of yourself. Now, what if you've had top surgery and had this removed? You do still need to be examining this part, because sometimes surgeries miss tissue. Sometimes if you have had top surgery and you go off of testosterone and you still have ovaries, and so those ovaries produce estrogen, you can sort of form some more chest tissue up there or regenerate a little bit, and then guess what can happen? Yay. And also keep in mind, cisgender men can get breast cancer. So this is very important to keep in mind whenever you are examining your risk factors. You need to be examining your chest wall. Get on it. Anyways, so moving off of the topic of the chest. So this next section will be more for the transmasculine people on testosterone who still have a cervix, which, you know, if you haven't had like a total hysterectomy or anything, you probably still have your cervix. So what are the recommendations for that? I know transmasculine people, by and large, don't seem too fond of going and getting, you know, pelvic exam and pap smears and stuff. And I can tell you nobody really is. No cis woman I've ever known has ever jumped up and been like, yes, it's time to go to the place with the cold hands. It's not a thing. Anyway, leave that for me. Fuck that. Anyway. So with regards to cervical cancer screenings, which would be, you know, the typical pap smear, pelvic exam, things like that, what we take into account is your age, your, you know, sexual history and things like that. But in general, most of the major organizations agree that you should follow the exact same recommendations as cisgender females, because there's no real hard data out there that says that you should decrease your amount of screenings at this time. It does seem likely that it would decrease your risk for cervical cancer, maybe, but the jury is still kind of out on that. And so currently, what one of the major organizations, the American College of Gynecologists, whatever, obstetricians and gynecologists, sorry, ACOG, ACOG, I should have said that in the beginning. Anyway, so what their current recommendations would be is that you go in for a pap smear about every 3 years between the ages of 21 and 29. They don't routinely recommend doing this prior to age 21 anymore. You know, used to, they just, as soon as you started menstruating, they come on in, everybody. But now, wait till about age 21. So 21 to 29, unless you have some kind of concerns or some issues going on down there, then they may need to do it a little bit earlier. But for our purposes right now, a pap smear about every 3 years, not too shabby, between ages 21 and 29. Now, once you reach age 30, you can change things up. There's a couple of different things you can do. Discuss it with your provider as to which one is more palatable for you and acceptable for you. You could either do like a pap smear that is combined with an HPV test about every 5 years between age 30 and 65. That's not too shabby. 5 years. I mean, you could, come on. You could go in every 5 years. That's not terrible, right? Come on, 5 years. So every 5 years, go in for a pelvic with a pap, and they'll add on that HPV test as well. Or you could do a pap only every 3 years, which that seems like a raw deal if you can do it every 5 if you do the combo. And then there are some people who say that you could do an HPV test alone, not a pap smear, but an HPV test alone every 5 years. Me personally, I think I'd probably go for the combo just because it makes me feel more secure. That's just me. Discuss it with your provider. But this is between ages 30 and 65. You could potentially only have to go in there every 5 years. Now, if you have an abnormal result, then of course that's different. They're going to have a different time frame that may be every 2 years or every 3 years, just kind of depending on your risk factors and what the exact abnormal result was. But anyway, so not everything's all bad so far, right? You don't need anything till age 21, and then between 21 and 29, it's every 3 years with a pap smear, and then after 30, between 30 and 65, you could do every 5 years potentially. Come on, discuss it with your healthcare provider. Keep an open line of communication. So, what happens after 65? So, there are a lot of rules there. Basically, if you have several negative tests in a row, either several negative pap smears or several negative HPV screenings or whatnot, then you could potentially stop having pap smears and pelvic and all that stuff. It depends on your risk factors and what your results have been. Talk to your provider. So what if you've had a hysterectomy though? Did you know that people who have had hysterectomies can still get cervical cancer even though they don't have a cervix anymore? What the fuck? Anyways, so you can. There can actually be cells that get missed because, I mean, hey, you know, everybody's human and it's hard to see cells. You can't. So if you miss like a little grouping of cells, there's the potential that they could then morph into cervical cancer. And that would really suck, right? You're just clocking along, minding your own business, and all of a sudden you have cervical cancer, and you're like, what? I don't even have a cervix? What's that about? So this is a thing. You need to go still and get checked out. Though those rules with this as well, it'll depend on, why the hysterectomy was done in the first place, or like what your individual risks are for cancer, the history of your family, your own health history, your own pap smear history. Were they ever, positive for any kind of abnormalities? So you may need screenings still for up to 20 years after you have a hysterectomy. So be aware that just because you have a hysterectomy and you get rid of that cervix, doesn't necessarily mean that you don't still need to go in and get a test every now and again. So talk to your healthcare provider. Age 21 to 29, every 3 years. Age 30 to 65, every 3 or 5 years, depending. And then after 65, depends on what your previous results have been, but if you've had several negative results, maybe you don't need them at all anymore. And then if you've had a hysterectomy, you still probably need to get checked out for about 20 years after the fact. Talk to your healthcare provider. It's surprising what you learn out here, right? Anyways, moving on. Ovarian and endometrial cancers. So this is a misconception. There's a lot of idiotic tests that get sold online that are testing for these. There's no standardized test for ovarian or endometrial cancers that are screenings. Like there's nothing that we, collect from you, on a pap smear or blood work or something like that that's going to test for these. These are completely like clinical based decisions for testing. So it'll be based on like what you come in and you've had irregular menstrual stuff and pain and a lump or whatever. There's going to be some symptoms and stuff, and then we make the decision, okay, we need to do some testing, because there are no like super non-invasive tests to test for these. So there are no screening tests. So ovarian endometrial cancer have not been shown to be elevated in transmasculine people on testosterone. Be aware of that as well. And there are no screening tests for this. So this is not something that cisgender women or transmasculine people who still have these parts need to worry about getting screened for. But if you have symptoms of the abdomen or lower abdomen pelvic region or menstrual changes, you need to be communicating these things with your provider, because testosterone can cause some of these things, alterations in menstruation, cessation of menstruation, which is super cool, but communication is key. Make sure you're communicating. On to some transfeminine problems again now. So transfem folks, if you still have your prostate, what are you going to do with it? Cis men have to go in starting at around like age 40-ish, and, they get the digital rectal exam, they get the PSA test, which is the prostate-specific antigen test. It's a blood test they do to see if it's elevated. So what do you need to do? So first off, something to understand is, even for cis men, prostate cancer screenings are kind of controversial with some organizations out there, because of the amount of false results that they get that end up getting expensive tests needed and everything. So, just for example, the digital rectal exam, how much use is that? It's under scrutiny, because whenever as a healthcare provider I've ever done a digital rectal exam, what I'm feeling is a portion of the prostate. And it's only about maybe 1/3 of the prostate that I'm feeling in there. So what about the other 2/3? I'm completely missing that. I can't feel that. What if it's irregular or hard or nodular or something? Well, I can't feel that part. I can only feel the part I feel. And if that just feels normal and smooth, then I'm going to chalk it up as, well, it feels okay. And then following up with the blood test, the PSA, this is controversial as well to some, because elevated PSA doesn't necessarily mean that you have some kind of cancer or something. It can be linked to all sorts of things. If someone is sexually active the night before they go in, they can have different PSA results as opposed to if they were not sexually active. It's And then trans women, once you're on estrogen therapy, it's been shown that overall the serum levels of PSA drop, which doesn't mean necessarily that like your prostate problems drop. It just means that the amount of prostate-specific antigen being produced in the body is not as high. And so a lot of organizations argue that the usual cutoff range for what's considered high on cisgender men's PSA tests should potentially be lowered for trans feminine people, because y'all have overall lower levels of PSA whenever it's drawn, and that perhaps a smaller degree of change should be a red flag, as opposed to, like, just for example, I don't know, like cis men, let's see, 1 year they get their PSA is, I don't know, 2, and the next year it's 6. That would be pretty crazy. So it jumps up to 6. That's a red flag. But let's say trans feminine person has a 2 PSA 1 year, and the next year she gets tested and now it's 2.9 or something. It's not near as big a jump as the other person, but because y'all tend to run lower, there's a suspicion then that your jumps also may not be as high, and so that we should red flag the change a lot lower than what we would cis men. So again, there's a lot of argument and debate on the usefulness of the digital rectal exam, because it only feels a small amount of the prostate, and the PSA because it's just not very well established what the PSA range is for trans feminine individuals and what we should consider like red flag levels and normal levels. Certainly we look at symptoms as well. Whenever someone is coming in saying, I'm having difficulty urinating, I have some blood in the urine, I have this, that, and the other thing, that is looked at as well. There are some loose, there's some studies out there, and logically it does make sense that, trans feminine individuals would be at lower risk for prostate cancer overall when compared to their cisgender male peers. Because you are going to be exposed to testosterone much less over the course of your lifetime than cisgender males would. Typically, anyway, whenever you have trans feminine transitioning with hormone therapy, part of that is that testosterone levels tank. So you might go from a testosterone level of 600 on average down to 30 on average. And so now you have essentially just whapped your risk for prostate cancer, because much like breast cancer is related to exposure of estrogen over time, prostate cancer is linked to exposure to testosterone over time. And so by lowering your testosterone, you thereby lower your risk for prostate cancer. So that's pretty cool, right? Yeah. Take the win. Anyways, moving on. So colorectal cancer, nobody wants to get scoped. I know nobody wants to go in for the colonoscopy where they have the camera up your butt, whatever. Current recommendations are to follow regular guidelines, which kind of depends on your risk factors, your family history, and stuff like that. It could start around age 40. It could start around age 50. It depends how often they're done. It could be every 5 to 10 years, depending on the guidelines being followed and what your particular results show. Could be more frequently, depending. There are stool tests they can do that check like DNA that's in the stool and different types of blood and stuff. Those generally have to be done much more frequently, about every 1 to 3 years. And if you have any abnormalities found with those, then you jump up and you have to go and do the scope instead. So it's not necessarily a way to get out of being scoped at all, because they can have some, false positives pop up on there. But potentially, if for whatever reason you just absolutely can't get any type of scope done, the stool test where they examine the different blood or DNA or whatever that's in there could be a viable option. Again, it depends on your risk factors. talk to your physician, your nurse practitioner, your physician assistant, whoever it is you're seeing. Talk to them about your risk factors and what they recommend doing to follow up on these. You don't want to be that person. You just don't. It's not a good look. But anyways, so moving on, and this is going to be pretty much my last topic I talk about, is going to be cardiovascular stuff to do with estrogen and testosterone therapy. I know the video has been long enough. It's 30 minutes already. I'm sorry. So, briefly, osteoporosis, whatever, out of all the other stuff, I'm like, it's kind of a boring topic, but I mean, at around age 65, you follow regular guidelines for getting screened with like a DEXA scan or something like that, unless for some reason you have some kind of issue or something that would put you at higher risk for osteoporosis. It can depend on like how long you've been on hormone therapy and everything as well. Some places don't do hormone therapy as well as others, and they give you insufficient hormones, and then you can have bone health suffer if that's the case. Generally speaking, if you have good quality hormone therapy with testosterone or estrogen, you're going to be right along there with your cisgender matched peers, trans women, cis women, trans men, cis men. You're going to be around there. And so waiting till age 65 to get osteoporosis screenings is generally what is recommended, and that's what's recommended for cis people as well. Then cardiovascular risks, meaning like strokes, MIs, blood clots, things like that. In general, because there are some smaller studies out there that show, somewhat different results where, like maybe there's a little bit higher risk here or there for certain people when it comes to cardiovascular events. Overall, it appears that trans women take their baseline cardiovascular risks, whatever it was, whenever they were, assigned male at birth, and they had testosterone as their main hormone component, and now estrogen is their main hormone component, and testosterone has been tanked down to the ground. Now what we have is the cardiovascular risk essentially of cisgender women. We have flipped their risk profile from cis men to cis women profile. It will be slightly different, yes, than, everybody, because we were, one way hormonally previously, now we're a different way, but essentially overall it appears that we take the baseline risk factors of men and we change to risk factors of women. And the same thing goes for trans men. We take the baseline risk factors of women, cis women, and then we change to the risk factors of cis men. So, like just for example, your risk for, heart attack may go up going on testosterone compared to what it was at baseline. However, keep in mind that a lot of these studies failed to take into account the various stresses that and other components that trans people, whether trans femme or trans masculine, experience every day. Minority stress syndrome is serious. It is a chronic state of stress and anxiety that wears your body down, including your cardiovascular system. So minority stress syndrome works hard on you. Also, unfortunately, the LGBT plus community as a whole tends to have more smoking, drinking, and certain other drug use, usually as coping strategies from the depression, anxiety, and everything of society being such a shit. And because of this, we tend to see, complications from, if you're a smoker, you have a higher risk of, stroke. You do. And so they didn't take into account these things. They just looked at, okay, this person's transmasculine and they had a stroke, and so their counterpart didn't, and so they must have a higher risk. Well, okay, but what kind of risks did that counterpart have? Were they a non-smoker who worked out every day and, you know, whatever, had no other health problems, and then this trans person had high blood pressure from the get-go, very sedentary lifestyle, and smoked and drank? They didn't take that into account. Why wouldn't you take that into account? But anyway, so take some of these studies with a grain of salt whenever you know, if you go looking them up for some late night reading to put you to sleep. Anyways, so be aware that cardiovascular risks are there, but it's more just they're changing from what your baseline was to what your new baseline is at this point. It's not like we're taking someone who was assigned male at birth and changing their risk factors so dramatically that even cis men and cis women are just going to be like way better off than this person is on estrogen therapy. That's just not the case. You still fall within this normal range of risk factors for cardiovascular symptoms. Anyways, all that being said, it's been 35 minutes, and thankfully we have come to the conclusion of this video. I hope it was enlightening for you. I hope you didn't fall asleep too much. I really did like trying to watch these freaking boring damn continuing education videos from WPATH and from these gynecology sites and colorectal cancer site, and just tried to get these notes together just to give you a general broad idea. You really do need to discuss individually with your own provider, because each region, each state, whatever, its own medical association or whatnot may have its own recommendations. These were just general recommendations taken from national organizations, and so they are guidelines, they are not rules, and you need to talk to your own healthcare provider about your own risk factors, your own comfort level with everything, and take care of your body. If you have the parts, get them checked out. Like there's just, I know there are barriers in place, but if you get the chance and you have the opportunity, get them checked out, because you just don't want to, you know, cut your life short when it's something easily preventable, you know, easily treated. You know, for example, most breast cancers, you know, when they're found are reasonably easily treated, you know, and so you just don't want to be that person who's like, well, I'll just ignore this part of my body and hope it goes away. And then it ends up being the part of your body that kills you. Don't do that. Please. I love you all and I want you to be here watching my boring videos. Anyway, so if I find anything else I need to update, I will. I'm going to put, like I said, a link to that breast examination video in the video description. I will also put a link to our Patreon page. Remember, early access to videos, make requests, ask me questions there, maybe get your own case reviewed. It's, you know, all kind of little weird stuff on there that I'm going to try and do. I only just started it, you know, like last month, so August of 2023, the start. So anyway, more good things to come. I hope everyone's doing well. I hope you're keeping safe. And I don't know, just watch out, y'all. The world's fucking weird anymore, okay? Me and Zombie are gonna sign out now. Check you later. Peace.